Hello everyone, I'm Lorraine and I will be teaching you the pathophysiology and pharmacology of cystic fibrosis. Cystic fibrosis or CF is an autosomal genetic disorder that involves the fluid secretion by the exocrine glands in the epithelial lining of the respiratory, gastrointestinal, and reproductive tracts. So since it is a genetic disorder, it can be passed through by a genetic inheritance. So how does a person get cystic fibrosis? This infographic shows how a person gets cystic fibrosis from their parents. So it shows that when two people who are carriers have a child, there is a 25% chance of having a child with cystic fibrosis. And when one parent has cystic fibrosis and the other is a carrier, there is a 50% chance of having a child with cystic fibrosis. So the main playmaker in cystic fibrosis is the CFTR gene. What does CFTR mean? CFTR means cystic fibrosis transmembrane conductance regulator. It is a protein that functions as a transmembrane CAMP activated chloride channel. So this protein is responsible for regulating the flow of salt and fluids in and out of the cells in different parts of the body. It has a different classes of CFTR mutations, class 1 to 6, but the mutations from class 1 to 3 are considered more severe forms of cystic fibrosis than those from classes 4 to 6. So this chloride channel function of the CFTR protein in the epithelial cell apical membrane affects the lungs, upper respiratory tract, pancreas, liver, gallbladder, intestine, sweat glands, and reproductive tract, and it is essential for the osmotic balance of the mucus and its viscosity. Owing to this widespread of distribution of the CFTR protein, cystic fibrosis is considered to be a multi-system disease. So now that we know what a cystic fibrosis is, let us dwell on how we come upon this disease. So how the CFTR affects sodium channel? A The cystic fibrosis gene or CFTR codes for a chloride channel in the apical or luminal membrane of the epithelial cells in the conducting airways. So this is normally controlled by cyclic adenosine, monophosphate or the CAMP, and indirectly by the beta 2 adrenoreceptor, and it is one of the several apical ion channels that control the quantity and solute content of airway lining fluid. So, with the normal channels appear to inhibit the adjacent epithelial sodium channels, but in cystic fibrosis, one of many cystic fibrosis gene defects causes the absence or defective function of this chloride channel, which leads to a reduced chloride secretion and loss of inhibition of sodium channels with excessive sodium resorption. The dehydration of the airway lining, the resulting abnormal airway lining fluid predisposes to infection by mechanisms still be fully explained. So with this figure, we can see that cystic fibrosis starts in a mutation from a single gene in the long arm of chromosome 7, which encodes for the CFTR. So this mutation form the CFTR gene makes the epithelial membrane impermeable to the chloride, but the effect of this is relatively tissue specific. So in the sweat glands, there is normal secretion of the sodium and chloride into the lumen of the gland, but the reabsorption of chloride through the CFTR, together with the reabsorption of sodium in the ducts of the glands, fail to occur, resulting to a high concentration of sodium chloride in the sweat of an individual with a cystic fibrosis. When individuals with cystic fibrosis have a normal amount of sweat, but really high concentration in the sweat of sodium chloride in the sweat, which is one factor that we can consider with the patients having a cystic fibrosis. In the normal airway, chloride is freely secreted to the lumen through the CFTR channel, but with the person with the CF, the transport of Cl into the airway lumen is impaired, leading to secondary events such as reabsorption of sodium and water from the airways into the blood, therefore lowering the water content of the cilius, which lines the respiratory epithelium to become more viscous. So this defective mucociliary function and the accumulation of viscous secretion that obstruct the airway and may develop to a recurrent pulmonary infection. So there's also a pancreatic insufficiency, which is caused by the plugging of the mucus in the pancreatic exocrine ducts, which results in the atrophy of the gland. Because of the impairment of the gland, the pancreatic enzymes do not reach the intestine to digest ingested nutrients, and malabsorption of the fat, protein, and fat-soluble vitamins occur. So other disorders related to this are osteopenia and osteoporosis, which is relating to the malabsorption of vitamin D. Uh, since we know how cystic fibrosis work, let's talk about the pharmacology. We have the CFTR modulators. This is a class of drugs that target specific defects in the CFTR protein so that the protein can work properly. So these modulators do not fully restore the chloride flow, but they do improve the flow enough to help lessen the cystic fibrosis symptoms. There are currently three types of CFTR modulators. One is the CFTR correctors. It helps the CFTR protein form the right shape so that it is able to move to the cell surface and stay there for a longer time. So another one is the CFTR potentiators. It helps chloride move through the CFTR protein, which and providing a channel to the cell surface. So potentiators hold the gate open and they work on gating, conduction, residual function, and splice mutations. Another CFTR modulator is the CFTR amplifier, which is currently being tested. So the drug is not yet available. And the indications for the CFTR modulators are for patients with cystic fibrosis and with at least one F508del mutation in the CFTR gene, age 2 years and older. So we have a couple of considerations when taking this drug. It should be a morning and evening dose and taken with the fat-containing food approximately 12 hours apart. And in case you missed a dose, if 6 hours or less has passed, take the missed dose as soon as possible and do not take the evening dose. And the next scheduled morning dose should be taken at the usual time. Monitor for report of headache, abdominal pain, diarrhea, nasal congestion, watery nasal drainage, and sinus congestion. Monitor the liver function tests initially, then every 3 months for the first year to avoid hepatic toxicity. Do not take it with grapefruit. Follow-up eye examinations are recommended for pediatric patients and swallow the tablet as a whole. These are my references and thank you for listening.